Welcome back to the 2026 APAICS Health Summit. I'm Tanya Layden, Vice President of Development and External Affairs at APAICS. Our next panel is From Data to Decisions, Equity and AA and NHPI Health. Aggregated health data often obscures unique health risks, disparities, and access gaps across AA and NHPI communities. This panel will spotlight why disaggregated data is not just a data tech issue, but a critical lever for improving health outcomes, particularly as AI becomes more integrated in healthcare. Our next speaker is CAPAC Executive Member and Vice Chair of the House Democratic Caucus, Congressman Ted Lieu, from California's 36th Congressional District. Congressman Lieu serves on the House Judiciary and Foreign Affairs Committees and is working to explore how generative AI can improve patient care. Please join me in welcoming Congressman Lieu.
Hello, I'm Congressman Ted Lieu. Thank you for inviting me to join today's virtual health summit to discuss a timely issue of data disaggregation and its critical effects on the health of the AA-NHPI community. Despite being frequently grouped together, the AA-NHPI community is a culturally, linguistically, and ethnically diverse population. The blanket AA-NHPI category is still being used by hospitals and national databases. Classifying data by race can inform research and is used by policymakers to determine if there are disparate disease rates and health needs. However, the aggregation of data can mask the rich diversity within these communities and may cause some health trends within AA and HPI subgroups to be overlooked. A recent study published in Nature showed that the same stressors manifest differently across ethnic groups. Across the board, individuals who experienced greater social stress had poorer sleep, struggled to exercise, and used more nicotine, factors associated with higher rates of heart disease. However, important differences emerge between ethnic groups. Among Chinese Americans, for example, high stress was associated with an increased risk of diabetes, whereas among Filipino Americans, it was linked to high blood pressure. Asian Indians were most likely to experience poor sleep and physical inactivity when bearing the brunt of social stress. These differences require tailored support, but without moving toward the disaggregation of data, we cannot uncover these trends and get our communities the support they need. I am pleased that APAICS is empowering all of you to lead this important conversation on addressing key health questions within the AA and HPI community. Thank you.
Our moderator, Tanisha Carino, is a senior leader with more than 20 years of experience in healthcare and public policy, spanning government, public, and private sectors. She is currently a visiting fellow at the Duke-Margolis Institute for Health Policy. Tanisha has held senior leadership roles at the White House Office of Science and Technology Policy and the Centers for Medicare and Medicaid Services, and currently serves on the board of the World Health Organization Foundation. Please welcome Tanisha and our panelists.
Thank you so much for that kind introduction and for joining us for this important conversation. I'd like to extend our appreciation to APAICS for hosting this event. APAICS has long championed AA and NHPI civic participation and leadership across government and public service. Their mission, ensuring our communities are seen, heard, and represented, is deeply aligned with today's discussion. We're here to examine an issue that may seem technical at the first glance, but it is in fact a profoundly human topic. Whether our communities are truly visible in the data that shapes our health policy, research, and ultimately our lives. Across the United States, communities trace their roots to more than 50 countries and speak over 100 languages. This incredible diversity translates into significant differences in migration experiences, income, English language fluency, education, and access to healthcare. Yet much of our data reduces all of that complexity into a single category labeled Asian. When we do that, we erase disparities, we obscure health risks, we undercount our needs, and we design systems that miss entire communities. A major contributor to this invisibility is the persistence of the model minority myth. The idea that our communities are uniformly healthy, economically secure, and doing just fine. This myth doesn't just distort narratives, it shapes the way data is collected, how resources are allocated, and how policymakers perceive urgency. When we allow that myth to influence our systems, we create data that conceals inequity rather than revealing it. Today's conversation is about moving beyond that. It's about recognizing that data disaggregation is not just a technical challenge. It's critical to ensuring our community is able to live their healthiest lives. And as AI becomes more deeply ingrained into healthcare, the stakes become even higher. AI systems will only be as fair and effective as the data that they're trained on. If our communities are invisible in that data, we risk embedding that invisibility into the next generation of innovation. I'm honored to be joined by a panel whose collective expertise spans policy, community advocacy, health systems, and clinical research and innovation in public health. Each of our panelists brings a different vantage point, and together they reflect the multifaceted solutions that are required to ensure our communities are not left behind. With that, I'd like to welcome our panelists to introduce themselves and begin with a foundational question for our panelists. Why do you believe it's important to more deeply understand and collect data on the lives of our communities? Juliet, let's begin with you.
Thanks so much. Wonderful to be here. Juliet Choi with the Asian and Pacific Islander American Health Forum. I always wonder, will the discussion of data ever hit the front page news of the New York Times? We absolutely need disaggregated data to understand who we are, what's happening to us. And in the context of health, I'm going to put it very starkly. It can literally be a life and death matter because without data, we just don't know. So the reason why I say it's a life and death matter is, on one hand, did you know that cancer is the leading cause of death for Asian Americans, Native Hawaiians, and Pacific Islanders? If you know that fact, then we would be curious and we understand how is cancer impacting the diversity of all of our populations. With this, I want to tie, this is why cancer clinical trials is so important. And when we put some numbers together, I think you'll find this pretty startling. From 2010 to 2022, enrollment in cancer clinical trials for Asian patients in the United States was less than 1%. Less than 1%. For Native Hawaiian and Pacific Islander patients, this number falls to less than 0.02%. Now, we know, thanks to the American Cancer Society, that more disaggregated data is being made available through their research. But when we think about it, I will raise liver cancer as an example. The liver cancer death rate for Asian Americans is 40% higher than our Caucasian counterparts. And when it comes to stomach cancer, Asian Americans are twice as likely to die compared to their Caucasian counterparts. I think this is a stark illustration of why having data, understanding who we are, how the research can impact us is absolutely critical. I think the last point that I'll make is investments in our public health infrastructure and prioritizing investments in creating disaggregated data systems to understand the well-being and the public health of the American public is absolutely critical.
Thanks, Juliet. We're going to get into those topics even more in our discussion, but thank you. Vayong?
Good afternoon, everyone. Thank you for the kind introduction, and I'm really happy to join this esteemed panel of leaders. I just wanted to first commend the framing and naming of this panel, from data to decision making, and I want to just emphasize that these data points, whether we're looking at disparities and inequities in diabetes, cancer, COVID-19, myriad of public health issues. These are stories, these are people, these are communities, and oftentimes these are inequities that are preventable, avoidable, and unjust. And so your framing and naming of this as not a technological or technical issue, but I would say that it's a political determinant of health, and recognizing that all of these inequities across issues we have the ability to prevent. And so representing Blue Cross and Blue Shield of Minnesota, I want to enter this space with a balance of humility and conviction. We know that we have a long ways to go on both the data and on the policy systems change front, but we did proudly sue the tobacco industry here in Minnesota, along with the Attorney General, and we are still very much in depths of that challenge and that struggle against the commercial tobacco industry. And ironically, or maybe not ironically, it is precisely the industry's ability to disaggregate data very, very carefully, to study. They may have called it market segmentation, or instead of disaggregated data, but they look very closely at our diverse cultural and ethnic communities. And I think there's a lesson here for public health and healthcare to apply that certain same kind of rigor and analysis to how we design our policies and our interventions. And so I'm happy to be with you all and look forward to digging deeper into these issues.
Thank you so much. I'm really looking forward to hearing about some of the success you've also had in Minnesota. Fiby, on to you.
Thanks, Tanisha. Hi, everyone. It's so great to be here today. My name is Fiby Daniel, and I'm the Strategy and Data Insights Manager on the Representation and Clinical Research, or RISE team over at Amgen. Now, the RISE team is a dedicated team at Amgen that is focused on improving the proportional representation of Amgen's clinical studies, specifically by focusing on addressing some of these systemic barriers of those who have been historically underserved and underrepresented, specifically as it relates to clinical research. Juliet did an amazing job at opening up this conversation about clinical research and the different data points and stats surrounding Asian Americans specifically. A couple of the stats that you had mentioned, Juliet, you took the words right out of my mouth, so I won't take time to reemphasize them. But really, the crux of this issue, especially from a clinical research perspective, is that we just don't have the data when it comes to Asian Americans as a whole, but even more specifically when it comes to that subgroups of Asian populations. We just do not have the data. And when it comes to data, data informs almost every single decision of our lives in some capacity. We, as Asian Americans and Asians abroad, are a really large, beautiful, heterogenic population. And Tanisha, in your introduction, you had mentioned that we lumped our population into this category of Asian American. And when we do that, we lose the nuances of what that means. And so until we have holistic data, until we have that disaggregated data, it's really hard to dig deep into what is actually affecting the different parts of our communities.
Fiby, thank you. Would love for you to get in more detail to give us sort of the status check of where things stand. We're going to start today with going a little bit even deeper in the issues, but I promise you that we're not going to leave our audience with just a regurgitation of all the issues, but give them some hope for some of the early signs of promise that we see. I want to start with you, Juliet. We've had major insurance reforms in the last year. What are you seeing today on the impact of these insurance cuts to our population, our communities?
Sure, absolutely. For our communities, I want to say it's a lot of anxiety, confusion, and concern. I think we've been following the news headlines, but just to frame the concerns here. Having access to insurance really is the gateway to healthcare. And with last year's HR1 or OB3, that piece of legislation, at least in the healthcare context, does propose close to $1 trillion in cuts to federal Medicaid spending over the next decade. To put some numbers and color to this, and a conservative forecast is that more than 10 million Americans will face losing Medicaid coverage altogether. That's almost 8 million whites, over 4 million Latinos, 2.6 African Americans, and over 1.1 Asian Americans, Native Hawaiians, Pacific Islanders, and a conservative estimate of over 200,000 Native Americans. In terms of the confusion and the concern, if we really try to put ourselves into our community partner shoes at the local level, the complexity here is that Medicaid, for example, is a federal state program, and it is going to be up to each individual state in terms of how they decide to deal with work requirements, new enrollment requirements, appeal requirements, and translating that in a way to make sure our community partners understand the impact and have the ability to explain that to that individual who is seeking to enroll or appeal their Medicaid coverage. So it's creating a lot of confusion and concern, and there aren't a lot of answers. In equal part, states are in the middle of trying to decide how are they going to implement these new Medicaid changes. So again, right now, really the climate is a lot of fear, anxiety, and concern, not just for our communities, but equal parts with our local and state government partners as well.
Thanks, Juliet. I really appreciated that data broken out in terms of what we're predicting in terms of the insurance impact. I wanted to also give you and Vayong the opportunity to talk about a little bit more about the public health emerging issues that you're seeing. And Vayong, do you want to go first?
Sure, I'm happy to jump in, and I welcome my other panelists to chime in and riff off of what we say too. So please don't hesitate to jump in. As I mentioned earlier, I have origins in commercial tobacco control, in passing smoke-free ordinances. We fought very hard on raising taxes on cigarettes and commercial tobacco use. And I just want to distinguish again between commercial tobacco and the sacred indigenous use of tobacco. And what we're talking specifically here is the behaviors and the actions of the industry and its impacts on our communities. And although I have roots in tobacco control, we've seen these deep racial health inequities permeate across all the determinants of health, from whether we're looking at graduation rates, insurance coverage rates, everything from epidemics to pandemics. And we saw that very, very, very starkly in COVID-19. And I just want to, in my limited time here, just want to illuminate a pervasive pattern that cuts across all of these issues. And your framing of data to decision making, I think really highlights that health equity, and specifically to our communities, the Asian American and Pacific Islander community, we have been erased, we have been invisible. And this is not only influencing data points, it's influencing investments, policy prioritization, and real community impacts. And so although we continue to focus very clearly on food security issues, like we helped lead the charge on passing universal meals here in Minnesota to provide free breakfast and lunch for all school students. We fought for community impact notes, which would then embed a community analysis from looking at disparities, demographic changes into the way we construct bills, similar to a fiscal note. But we're saying we can't just look at a bill in cost benefit terms, but look at the human impact here. And specifically, would a bill create more or less gentrification, food security? Could it potentially widen a gap there? And so we feel very strongly that it's important to insert strong, rigorous, disaggregated data into the construction and the analysis of bills. Really, in our kind of health terms, it's early detection, it's rigorous forecasting, it's sound analysis, and that only happens with disaggregated data, so we don't mask the disparities that we're facing. And that applies to all issues, whether it's food security or commercial tobacco use or vaccines. And so we're really trying to go upstream and affect the policymaking process itself. So I'll leave it at that, but I just want to make sure that we're not looking at this at just in terms of issue advocacy, but in terms of systems change.
I love that reminder that without that data disaggregation, we're not just talking about having deeper data on healthcare, the way it's financed, insurance markets, or whether it's delivered, but also the broader public health and social determinants of health data that really impacts every bit of our our health outcomes, more so even than the healthcare system itself. Before we move to Fiby to really talk through a little bit more detail the importance of our communities and participating in research and where we stand today, are there any other perspectives in terms of how we think about data and the different kinds of data that we really want to tackle moving forward?
I just think that when we're looking at data disaggregation, we're looking at qualitative data. We're looking at we're not dismissing the importance of community wisdom, if you will. And I often think about my parents who, along with myself, came to this country as refugees, and their stories, the way they share their history isn't even written. Our language just became a written language 50 years ago, and much of our traditions and our health knowledge is passed on through embroidery, through folklore, through stories. And so your typical data surveillance and collection processes don't capture that, right? And so I just want to make sure when we're thinking about data collection and the processing and application of that it's not just in quantitative terms. I'm sure that's very profoundly obvious to this group, but I just want to emphasize that. Mm-hmm.
Great. Mm-hmm. Juliet.
I would just add that, what we have observed over the last year is that where traditionally certain disaggregated data sets were available at the federal national level, those federal data sets are either being removed or the rigor, the infrastructure, the commitment to collect certain disaggregated data sets, that commitment has discontinued from the federal government, particularly at HHS. And so as today we're talking about how disaggregated data, and this should not be a political issue, disaggregated data allows decision makers, whether you're from the private sector or the public sector, to make very informed decisions and allocate already limited resources for enhancements and improvements in the public health system, as well as to tackle some of those disparities. So I think a larger conversation that includes the private sector is how can multi-sectors, particularly the private sector, be a champion for wanting to grow and build an infrastructure for the purpose of collecting disaggregated data. We know that exists, but I think going forward, there's certainly an opportunity for a more collaborative, more coordinated framework to make sure that this country does have the disaggregated data to make very, very informed decisions when it comes to allocating limited resources and really trying to make improvements in the lives of Americans.
Juliet, I love that reminder that, we're talking about disaggregated data and a wide range of data types and the richness of data. There is a conversation that we need to have about what is the most efficient way of collecting that data. And absolutely, there's a role for the private sector, but I think that there is also a role for other government bodies to make it more efficient. Fiby, on that note, do you want to talk a little bit more about the work that you're doing and where we actually do stand, at least as it relates to collecting data from a clinical research perspective?
Yeah, thanks, Tanisha. And thank you, Juliet and Vayong, for all your perspectives on data collection. I actually want to take a step back and talk a little bit about some of the barriers that Asian Americans tend to face when it comes to clinical research, and we'll end with a couple of solutions that might be beneficial for our population. And I'm actually really glad, Juliet, to see you here on this panel, because I remember when Amgen partnered with the Health Forum last year to investigate the attitudes and perceptions of Asian Americans specifically as it relates to clinical research. The data sets were fully disaggregated, along with some aggregated data to see how they kind of contrasted and compared. And the full report can be found on the Health Forum's website. But in the literature and the research that's been conducted to date, we do see that minority populations report mistrust, lack of comfort with the clinical research process, time and resource constraints, and lack of awareness of clinical studies as some of the primary barriers as to why they don't participate in clinical research. When we conducted our survey in collaboration with the Health Forum, actually, we found that for Asian Americans specifically, we found that the lack of awareness awareness about clinical research and a lack of opportunities to participate were the primary barriers. So this really poses a very unique opportunity for the Asian American population and a pretty strong call to action for the healthcare industry. These can be seen as very small changes, like including culturally concordant translated materials surrounding clinical research, support with complicated informed consent forms, and providing translation services where possible. But it can also look like making sure physicians are offering clinical research as an option where it makes sense for Asian Americans to really boost and raise awareness of these opportunities for our population. The goal really here is to encourage these conversations in our communities and to make sure that we all understand what clinical research is versus what it's not, increasing those health literacy rates, and making sure that our populations are seeing the data that we're collecting.
Maybe I appreciate you've already bridged us to some solutions. And I want to continue to dig into the solutions that you all have really experienced and been part of. Vayong, one of the most profound periods of time, I think, for all of us was what we all learned during COVID-19. I'd love for you to reflect on what you learned in COVID-19 and how you in Minnesota have been trying to reduce the disparities related to COVID-19.
Thank you for that question. I think we're still processing some of the lessons learned. And although we're 6 years out from the outset of COVID-19, of the COVID-19 pandemic, I think we're still, in some ways, triaging that. It may seem far distant, but we're still processing kind of what does this mean for the public health infrastructure? What does this mean for the role of community health workers? What does this mean for, whether it's healthcare providers or health insurers? We're still looking at the whole apparatus and recognizing that the pandemic helped mainstream public health declare racism as a public health crisis. And as a friend and partner to the public health infrastructure, I asked my public health association, the Minnesota Public Health Association, if it took us to 2020 to declare racism as a public health crisis, what does that mean about the racism, the built-in structural racism within public health itself, right? And that's not to blame any one sector. That is to examine the role of structural racism across different systems as an interlocking mechanism. And so I think what COVID-19 really showed us is that we saw stark racial health inequities from exposure, infection, hospitalization, treatment, and death. And when we looked at a global level, Asian Americans seem to be doing on par and collectively we were all doing bad as white Minnesotans, but only through the prompting and the advocacy of community-led organizations, Coalition of Asian American Leaders, CIRAC in DC, and nameless elders and leaders in the community prompting this, asking our health department, we're seeing a lot of suffering and struggle in our community, and you're not detecting it. You're not lifting it up. And so in partnership with the University of Minnesota, they were able to drill down and disaggregate data, oversample, go out into community, talk with folks, and made sure that they didn't rely on just mainstream data sets. And what that data revealed was that when you looked at Southeast Asians, immigrants, refugees, you saw much higher numbers in death and from COVID-19. In 2020, we saw that the leading cause of death for Hmong and Karen refugees was 29%, and for white Minnesotans was 11%. And then when you look closer at age groups, in the age group of 50 to 64, the Hmong elders were passing away at a 35% rate, compared to only 6% for white Minnesotans. And those are just emblematic of other inequities. And I'm not saying this to minimize the struggle of other cultural ethnic groups as well. As you mentioned earlier, a lot of this is rooted in the model minority myth. And I think it's important for us to recognize collectively that myth itself was prompted and created out of anti-Blackness and a effort to pit our communities against each other. And I just want to make sure that in this space, we're mindful not to perpetuate that inadvertently. But I think what this report showed us is that COVID-19 just didn't create these inequities. It really made it undeniable that these structural inequities were in place all along and were simply more magnified and exacerbated. And we see a clear link between pandemic inequities and epidemic inequities. But I'm happy to put the report in the chat here, and we can dig in more later.
I love your example because it took the advocacy of your community leaders to make sure that data was being collected, and it almost validated what they were seeing. But having that data collected gave much more urgency to the resources that needed to be allocated. As you are moving towards those lessons learned, what have we seen in terms of the importance of engaging these community-based organizations in actually addressing the problem or changing sort of the trajectory moving forward? And I wanted you to reflect on that particular example for COVID-19, because Juliet, your organization has done some great work on where these types of organizations stand today, and I'd love to continue that discussion. But Vayong, before we move further, how did they then become a partner in trying to bend the trajectory of what you're seeing in terms of health outcomes?
Yeah, there's so many lessons learned there. I would just want to emphasize that maybe the greatest kind of epiphany we had was to approach public health as civic engagement and as change agency, and not as a data technical change. Certainly we need to kind of break down categories of data and populations, but making sure that as we talk to Hmong elders to go testify at the Capitol about the need to have mobile vaccine shops go to the Hmong village, go to Hmong shopping stores, to get them to testify and to participate, many of them would say, Vayong, we don't know anything about public policy. We don't know anything about policy change. And I would have to counter politely and say, well, do you know about our funeral customs, how we celebrate the new year? How do we welcome a newborn baby? That is policy change. We've known about it for millennia. We just don't use the same words and terminology. And so that helped disarm many of our youth and elders and to participate in policy change and not make public policy esoteric or defer it to those who were raised in this country and had the kind of professional background. But I think that awakening, if you will, that we are equipped with change agency before we even came to this country.
That's great. Juliet, I know your organization recently completed a survey of community-based organizations. Do you want to expound on their role and the importance, and how are they doing today?
Sure. Yeah. Thanks so much for that question. So the health forum starting in 2020, this really was as a result of COVID. We want to capture and memorialize what our community partners were experiencing on the ground. So this is our 5th year conducting our annual survey. We believe it's the only survey that really captures the voice and perspective of local partners on the ground who deliver healthcare and human services. What we did last year is we did a mid-year pulse survey. And if we think about where we were almost this time last year, there was a pronouncement of so many proposed federal changes and executive orders. And anytime there are policy changes at the federal and national level, the impact for local community partners is confusion. How do I make sense of all of this information? How does it apply to me? And then how is it going to impact the communities that the families and the individuals I'm trying to serve? So our mid-year pulse survey, we conducted this between May and June of last year, had almost 100 respondents, so a third of our 300 plus partner network, and 75% or 3 out of 4 of our community partners stated that they have a lot of fear, anxiety, and uncertainty. I think understandable. Over at 50% of our respondents had stated that they question how their mission of their organization is going to get impacted by these new proposed federal changes, whether it's immigration, healthcare access, attacks against birthright citizenship, and language access, right? Declaring English as the official language. Again, mid-year, 50% of our partners anticipated losing federal funding. Also, mid-year, 37% of our partners reported having already lost federal funding. And again, that's just mid-year last year. And then some of the real concerns and unmet needs really comes down to how do we ensure that there is a trusted source and voice when it comes to public health information? We've talked about COVID today. Certainly, navigating accessing vaccines is actually a very top priority to us, to our communities, because of the lessons learned from COVID. And on vaccinations, I want to just highlight there has been a big concern where, when it comes to hepatitis B, over 50% of Americans in the United States with hepatitis B are actually AA NHPI. And also, there is new CDC guidance that does remove the mandatory requirement for hepatitis B vaccinations at childbirth, which really is going to impact our young people going forward. The other concerns also, it really does come down to how do we help ensure our families can access health insurance and therefore health care. Earlier, I spoke about the proposed cuts to Medicaid, but there's a higher level of lack of insurance that we are all collectively concerned about as it relates to the marketplace. Again, with HR1, I do want to highlight with the expiration marketplace tax subsidies, there is a forecast that 20 million or over 1 million AA NHPIs will lose access to marketplace. And then we've talked about, I think all of us are either first generation or second generation immigrants, refugees, asylees. There's someone in our orbit we know falls into that category. And for the first time, and I don't think the general public appreciates this, that refugees, asylees, humanitarian immigrants, which include survivors of domestic abuse or labor and sex trafficking, are no longer eligible for marketplace insurance, as well as our young people, DACA recipients, are also no longer eligible for marketplace. So again, if we put our place in the shoes of our community partners who are trying to navigate this enormous amount of change, we really are left wondering how are we going to ensure our communities actually have access to health insurance and healthcare writ large. And then, I'd be remiss if I didn't state, immigration status is definitely a non-medical determinant of your health status today. Because of the fear factor. And so those are some very, very real, very big issues our communities are facing right now. And to be quite candid, I don't know what the answers and the solutions are going to be going forward.
Well, I appreciate that, because we've talked about a range of issues, both from the short-term impacts of health policies it stands today and some of the issues that are happening in public health, all the way to the need to address the integrity of our data moving forward and its representation, particularly in light of AI and what that will do to accelerate the disparities that exist if the data isn't in the systems that they're being trained on. I know we only have a few minutes, and I know, Juliet, it may be a stretch to have a solution, but you all are so amazing and are so deep in this area. For our listening public, what is the one critical action that we have to take to be able to address the full representation of the experience of our community and begin to bend the disparities that we all see as front and center today? Fiby, do you want to go first?
I can go ahead and kick us off. It's a bit of a daunting call to action, just because when we're talking about data and we're talking about data disaggregation and the current gap that we see, it's large. And so from a clinical research perspective specifically, this really starts with normalizing conversations about clinical research and representation. It starts in our communities, absolutely, in our homes and across generations, but it also starts in the places where we work. For those listening who may be in the healthcare sector, in the healthcare field, it starts by acknowledging some of those implicit biases we might hold. And it starts by really addressing where that comes from and working to decrease some of those biases that we see. Because representation at the end of this, all of this, I believe Vayong and Juliet touched on this. Representation is having that data is the crux of how we make decisions. Without that data, our decisions are biased and our decisions might not be beneficial for those we are actually making the decisions for. So representation matters. It's the cornerstone to ensure that the future of medicine and the future of policy reflects and serves all of us. And I'll leave it there.
Great. Vayong, do you want to go next? What's the one critical action that you would love to leave our audience with?
I'm going to go back to civic engagement and change agency. That whether we're trying to change a methodology or public policy, that this isn't a challenge about process or a certain kind of like data set. I think we're ultimately facing a political and policy problem, and getting community residents, citizens, folks involved with changing their environments, the systems that impact their lives. And I that's where I'm going to put my emphasis is on civic engagement and personal agency.
Great. Juliet, to bring us home.
Well, I'm going to riff off of this theme of civic engagement. It is so critical for us to exercise our voice and make sure that we're seen. And in that spirit, you did give me the chance to highlight some of the real concerns, from the health forum's perspective when it comes to access to healthcare and the concern of the lack of data. So my actionable item is thinking about civic engagement. I think being engaged somewhere at a state government roundtable is going to be critical. And very specifically, I would love to see what is our AA and HPI representation at state Medicaid agency tables. And if we don't have someone there, this is not just about our community. I think this is the governors and our coalition partners help us get a seat at the table so we can discuss how insurance enrollment is going to play out for our most vulnerable, alongside with, we know that CMS is actively looking at public comments on how AI can be utilized. And there can be a lot of solutions and innovation out of AI, but there is also a danger that it can perpetuate some of the stereotypes and the data gaps. So let's get a seat at that state Medicaid agency or at some table that the governor offices is convening so that we are seen and we are heard.
Well, I want to thank this panel for your thoughtful and powerful insights. And thank you to APAICS for creating the space for such a critical conversation.
Thanks, everyone.
Thank you, everyone.